Scott, you just read an email for me. Tell me about it.
Yeah, so one of the patients that we did a SI joint fusion on about 6 weeks ago reported to her provider that she has complete resolution of her right-sided back pain, and we did the right-side SI joint injection, and she said her pelvic pain is completely gone as well. So she did really, really well with a 1-inch incision.
That is why we call that a miracle. We have two words, two other terms for sacroiliac joint. I'm an expert. One is miracle joint, because people who go through the pain for years, you do the surgery, 4 weeks later they want to stand up and hug you. The other word we use for that, we talked about, that is the chameleon joint, because it can pretend to be like hip or lower lumbar spine or something else. So you're just starting feeling the feedback. Some of them are going to stand up and hug you.
Yeah, these patients all do really well with a sacroiliac joint injection, but the duration of relief is very, very short-lived.
Which is supposed to be, because it's a diagnostic injection, you just put a medication. But once you have 3 positive injections, and note that we are talking about that, the criteria for the injections are well defined. It's a low volume injection, 2 to 3 cc local anesthetic.
So I use about 3 cc's of 0.25% bupivacaine, and I put some steroid in there because sometimes it does provide long-term relief.
Yeah. What I see as well, that they get better, they get worse, and a week later when the steroids start working, they get better again. So that's sometimes what I see. There's a two-phased kind of improvement.
And I think most of my patients are ones that I've selected for SI joint fusion are those who really only get pain relief for the duration of the local anesthetic.
That is exactly the criteria. Now, the contrast, the confirmation is required, some imaging is required, CT or X-ray per protocol, and as well, it's supposed to be in the articular or the boomerang part of the joint. But people who do that, like you, are well familiar with that. So not every sacroiliac joint injection is a diagnostic injection. But it can be therapeutic by putting steroids.
And I explained to the patient that it's diagnostic as well as therapeutic. And the key thing that I instruct patients about is to really pay attention to how they feel in the first few hours after the procedure. Because they may come back and say, no, it didn't work. But if you ask them, how did you feel the day of the procedure? They say, oh, it was wonderful. And in that sense, it is a successful injection because it's diagnostically told us that it's likely the sacroiliac joint that's causing the issue.
So what are the pitfalls, since we are talking about that, what do you think, what are the pitfalls of diagnostic and treatment for the sacroiliac joint? Because believe it or not, we have neglected that for 70 years. We are just coming back in the last 20 years to the being able to diagnose it properly and treat it efficiently.
So in our practice, we will often focus on the facet joints as a pain generator for the back, but we'll do medial branch blocks, radiofrequency ablation. But I have many, many patients who come back after the radiofrequency ablation and say that they still have some residual back pain. If I go back then and treat the sacroiliac joint, sometimes I'm able to get complete resolution of back pain as well. The reason for that is that the referral pain pattern for the facet joints overlaps significantly with the sacroiliac joint.
Yes, they do. Now, for the treatment, for the fusion, you have done a great job in the last 3-4 months to be able to do this procedure. So what do you think for the procedure, if somebody's starting with that, should think about, or what are the pitfalls for the treatment, surgical treatment of it?
So I guess in patient selection for me, the classic patient or the ideal patient that I think would very much benefit is somebody who has had a fusion, a lumbar spine fusion. So their facet joints are fused and shouldn't be causing any pain. And then you do a diagnostic sacroiliac joint injection and they get complete pain relief for a short time. And then you do it again, they get complete pain relief again a second time. But they just can't get long-term relief. And the other patient, there seems to also be another patient population, younger women who have had children, seem to have somewhat laxity in their joints, and the sacroiliac joint injection and treating the sacroiliac joint can be very helpful for them as well.
And you just described the typical younger woman in childbearing age. As a matter of fact, the incidence of sacroiliac joint is 7 times higher within 2 years after delivery. So you're just describing from your experience. What statistic confirms as well. What you just confirmed, what statistic confirms, about 24% of the native back pains are sacroiliac joint related, but if you had a surgery in the lower lumbar spine fusion, that jumps to 43%. So you've just from your experience
Yeah, that's my
recited
observation.
practically the statistic that's out there. Now, what do you think about the trident specifically?
Oh, so I looked at many different methods of fusing the sacroiliac joint. There are posterior approaches which are maybe more familiar to a pain physician in terms of their placement. But in talking to other physicians who have done many of those, they found that the fusion was incomplete. And then those very experienced physicians told me that they went to a lateral approach fusion. So
Yeah,
I sort of-
lateral to medial rather than medial to lateral.
Exactly.
approach.
Well, for pain physicians, a percutaneous lateral fusion is what
Yeah.
some pain physicians do. But I looked at all the other systems out on the market, and although I know physicians who are using them, the Trident system is much, much easier to place and much safer, in my opinion, because you have to just place the middle stabilizing screw is what I would call it, and then the other two screws that you place to reduce the risk of torsion. The Trident system provides a fixed pathway to place those screws.
Yeah.
And so it's very simple. You take a lot of time initially to just get your imaging correct and line up the sacrum. But then once you place your guide wire, it's very simple after that.
Yeah, and as well in my experience in other system is that in one of 7 cases, about somewhere between 15 to 10% of the cases, in a regular system, you put a small drill, then you put a big drill, then you put a tap, and then you put a screw in. In that steps between where you go from literally from you have a 1 centimeter drill inside of the bone, it starts truly bleeding a lot.
Right, and that was the other thing that
yeah.
I was very concerned about is
Yeah.
intraoperative bleeding.
Yeah, and that is, as in a surgical situation, certainly you can deal with that in a hospital, but I think that makes it less suitable for a surgery center. When you start bleeding like 500 cc in 3 minutes,
Yeah, I don't want that.
everybody becomes nervous. Yeah. Well, thank you, Scott. I really appreciate that.